Dear colleagues, today we will take a look at how the Damon system allows to manage two very interesting problems in orthodontics. One of them is the crossbite, and the other one is the deep bite. Depending on what orthodontic system we use and which philosophy we follow, we as orthodontists know very well that our main priority is, when we see a patient with a bite pathology, is to unblock the malocclusion. What does it mean? First of all, is to solve the transversal problems, then the vertical problems, and then finally the sagittal problems. Let's begin with crossbite. As we have already noted, one of the main and most important problems to be faced and that we need to solve early in our treatment is the transversal problems. The transversal discrepancies between the width of the upper and lower arches lead to the crossbite or to the Brody. We will see the crossbite where we have a superior contraction, the contraction of the upper jaw, or we're going to see a Brody where we have an upper excess or lower contraction. They may be monolateral or bilateral, and they may be anterior or posterior. One of the great advantages of the Damon system, among others, is the ability to tackle various problems without using annoying auxiliaries such as extraoral tractions, expanders, or palate bars that are not very comfortable for our patients. Naturally, this is a great advantage, especially today at the time when we have a lot of the adult population coming for the orthodontic system, especially for the Damon system, primarily due to aesthetic desires or aesthetic complaints. Everything that we can achieve thanks to the Damon system, thanks to its enormous possibilities of remodeling and developing the dental arches, is possible only when we know the technique well according to the protocol. This is why we will take a look at how this technique allows us to solve those problems without additional or adjunctive devices. Thanks to which mechanism does Damon allow us to solve such problems as crossbite? We said that we will use the remodeling potential of the dental arches. And in fact, it was Damon 25 years ago who demonstrated how, with the use of orthodontic forces that are lower than the muscles of the lips, our dental elements can slide distally and transversally, which becomes the path of least resistance for them. Because with our arch wires, we develop low forces below 40 grams, and our teeth will not be moving forward when the lip musculature works physiologically. The strength of the labial muscles will be above 40 grams, which will counteract the orthodontic forces. It will be enough to keep our teeth away from this forward movement. This is why we need to pay attention to those patients who may have labial incompetence, where the muscle tone is low. Indeed, the lip muscle tone can be lower in them, so we will need to use the arch wire even lower, with a lower force, for example 0.13, as well as to give exercises to patients so that they increase their perioral muscle tone. Dr. Damon has demonstrated through multiple research what happens in crowding cases. Most importantly, what helps us tackle the crossbite is that in severe crowding cases, systemic work with the arch wires allows us to achieve extremely important changes in the transversal plane. This happens primarily in the area of premolars and molars. This is the work done by Dr. Damon himself, where we can see how on the models he adapts the arch wires on the cusps of the upper jaw and in the crowding case at the beginning of the treatment and after the treatment. He does it with an extremely nice result. Later, we can compare the arches before and after the treatment, and we can see that the arch wires have a different length, which clearly demonstrates how the length of the dental arches is increased during the treatment. Here, it has been increased by 12 millimeters, for example. All of this is achieved by expanding or broadening the dental arch on the Damon system without using any other expanders or devices. So we have seen an increase of a dental arch length by 12 millimeters with the Damon system only. It is also interesting that if we take a look at the line, the distal on the first molars and the line in front of the incisors, and we compare those lines before and after the treatment, we will see that their difference is only 1 millimeter in that length, in the distance between those lines before and after the treatment, which means that we have not seen any flaring, which is very important for the incisal group, because this is something that is very often criticized. And this naturally would lead to a transverse growth, a transverse development of the dental arches, as we see here as demonstrated on models. When we check the distance between certain cusps before and after the treatment, we see that, for example, that intercanine space has increased from 32 millimeters before the treatment to 34 millimeters after the treatment, which means we have gained 2 millimeters. This is very significant because we know that the intercanine space is a parameter which is practically impossible to change, or which is possible to change only insignificantly. This is why in canines we work with inclinations or rotations, but not in increasing the intercanine distance. This is true for both the maxillary and the mandibular dental arches. But even when we have the correction of such strong crowding, we have seen only 2 millimeters of an increase in the intercanine space. In the distance from 4 to 4, from first premolar to first premolar, we have seen an increase of 12 millimeters. Second molars, 11 millimeters. And molar region demonstrates as an expansion of 9 millimeters from molar to contralateral molar. So we have seen a development and an expansion of the dental arch, which allowed us to correct the crossbite without extraction. Also, we didn't have to use any additional palate expansion devices. One of the criticisms against this technique is a potential denuding of the roots when the roots of the teeth go beyond the cortical bone. Dr. Damon has conducted research that was published many years ago. It covers the case of this patient, where we can see what specifically happens at each stage thanks to the CT scan. where we can see the results of the expansion at the area of the first premolars, where we have the expansion of up to 12 millimeters. We have a very important CT scan section where we can clearly see then the roots of these teeth have a perfect coverage of the cortical bone on the facial surface. Here we can also assess that the axes of these teeth do not look as if they have been torqued excessively, which means that the expansion we have achieved definitely happened at the basal layer, because no other orthodontic system can work at the basal, at the bone level, but can only work at the dentoalveolar level. The same thing can be demonstrated in the area of the second premolars, where we see the increase of 11 millimeters. The axes of these premolars are absolutely upright without any vestibular, without any frontal inclination. The same thing is clearly demonstrated in the area of the first premolars, which clearly demonstrates that there are no issues of denuding dental roots from the cortical bone, as long as we follow the protocol, the time terms, and the forces of the treatment. We have also seen how the distance between molars and incisors changed by only 1 millimeters. Here you see the interposition of the images, where we see the face before and after the treatment. The face remains in the same profile, whereas the distance change occurs at the area of the molars, with the incisors staying in place. Already in 2017, we have seen this thesis published in the American Journal of Orthodontics, comparing the changes in the upper arch obtained with the Damon system versus those obtained with the RPE system, with the palatine expansion system. And the results have demonstrated that there is no significant difference in the molar tipping between the two methods. It wasn't demonstrated. Thus, the choice is up to the treating dentist, but with the correct treatment, with the following of the protocol, the two techniques do not demonstrate any difference. Let's now take a look at the details of how we work with the Damon system in crossbite problems. The biomechanical recommendations include the use of obligatory occlusal buildups in order to release the bite, in order to allow for transversal and lateral movement of the teeth with the application of light forces. We use most of the expansion potential of cunei arches. We completely avoid, or as much as we can, avoid extractions in the upper arch. High crowding is a favorable condition for expansion, to tell the truth. When we want to increase the volume, when we want to achieve expansion to correct crossbite, we cannot think about extractions, because extraction will contract the dental arch and will keep it narrow. Moreover, if we have a very negative torque in the posterior areas, we can use early cross elastics on round arch wires in order to achieve immediate torque correction. Because even as we use light elastics, we will be able to manage the situation. Ideally, it is to use cunei cross elastics on arch wires at all stages, because these are very light arch wires, which are very elastic, cunei 0.18 over 0.25. So as our dental arch is being uprighted, these light elastics will allow us to achieve expansion in the area where we are most interested to achieve it. Moreover, in the 18/25 Q-Nitaic arch wire, which has this excellent expansiveness and torque control, it's very well studied, it's very well known. We see not simply an expansion, but we also see the expansion relative to torque, or with the consideration for the correct torque. At the next phase, where we will go from copper nitide to stainless steel arch wire, we can use 0.16/0.25 without using the pre-posted arch wire, because we're going to use the wire for hyperexpansion. Because the pre-posted stainless steel wire, the elements that are welded to the wire change its elasticity. This is why if we want to use the stainless steel 0.16/0.25 for the expansion, we never use it pre-posted. Also, all the cross elastics that we use to correct crossbite should always be calibrated according to the arch wire that we are using at the moment, and we should apply those elastics in a triangle or box formation, and we can also associate them with the class elastics. It depends on what particular part of the bite correction we're involved in. Let's take a look at a few clinical cases that I have prepared for you. This is a very interesting expansion case, and we will also take a look at the biomechanical details where these concepts, the Damon biomechanics, have been applied in a patient. This is an unfinished treatment so far. So you can just see the crossbite at the initial situation. We see the patient with a crossbite in the area of 2-2, and from 2-4 to 2-6 there is a crossbite. On the other side, on the right, we see the maxilla completely overlapped by the lower, by the mandibular dental arch. The tooth 2-2 is completely in the palate. In November, we use the Damon Q system. I put the bracket low torque on 2-2, and I have used the open spring in order to create space for 1-2 and 2-2 teeth. Also, I use 0.14 copper nitide arch wires in the upper and in the lower. In March 2021, we have included the second molars. We have switched to copper nitide 14/25 arch wire in the upper and in the lower jaws. I start using cross elastics from this point on. Here we use kangaroo. They are 3/16 with 4.5 ounces of force. By adding a sagittal arch wire on 2-2, I'm passing it through the bracket and the additional openings of the adjacent teeth brackets. So until now, we have only been using 0.14 arch wires, which allowed already to align the dental arch. Now I switch to 0.14.25 arch wires, which start working to expand the dental arches despite it being very light forces. We will also add crossbite elastics and clasp elastics to expand more. Now we see April. We see the continuous expansion and alignment. We see the lateral incisor slowly sliding into place. Previously, it had moved very slowly from appointment to appointment. It's a very sort of customary for me, as I was regluing some of the brackets in order to achieve a perfect space. So here, for example, I have moved the bracket on 2-1. I have already attached the main arch wire through the bracket on the lateral incisor. Now we can see June 2021. I have reglued 1, 2, and from 1, 2 to 3, 2. Then I switched arch wire on the upper 0.18 over 0.25 lower in the lower jaw and 14 over 25 in the upper jaw. The mandibular dental arch is completely aligned and located correctly, whereas on the upper jaw I have replaced the low torque bracket with an irregular torque bracket, but I have put it upside down because the root of the 3-2 is positioned very facially. This is why I use this regular torque of 2-1 bracket, making the torque completely negative for 2-2. I keep 2-2 there, and I keep the arch wire 0.14 over 0.25 in order to avoid extended torque. I keep using the triangular elastics, 3.16, 2 ounces. Why 2 ounces and not 4.5 ounces? Because here I see the facial inclination in the incisal group, and this is why I lower the force of the elastics, because I just need to keep them open while the arch wire works on inclining and aligning the teeth. 14 over 25 arch wires continues to torque the teeth for several months. Now we are in July 2021. I can see a very good expansion. I have rebonded bracket 1-2 because I'm not happy with its position and I want to achieve perfection here. I have replaced the upper arch wire. Now it is a copper nitride 0.18 over 0.25 arch wire. I return to the kangaroo cross elastics and I add class 3 zebra elastics because as the expansion was developing, we need to keep the upper jaw and the front so that I keep class 1 canine bite. In September 2021, I have rebonded to bracket because gluing it upside down is very difficult. So I saw an extrusion of the tooth, but thanks to the elasticity of the arch wire, I can improve the position of this tooth as much as it is possible. Upper arch wire remains 18 over 25, whereas in the lower I switched to the stainless steel arch wire 19 over 25. The lower jaw is perfect now. I want to stabilize the lower dental arch while I'm working with the upper arch. I keep the elastics because the expansion has been satisfactory. And in October, I have decided to rebond 1, 2, and 2, 2. I have put a super torque bracket on 2, 3 in order to improve its position, as well as the position of the root, whereas 2, 2 still have a very negative torque. The elastics are still worn, despite the alignment of the dental arches, despite the correction of the inclination. I still need the elastics in order to prevent lingual inclination of the teeth. November 2021, I switched to the TMA arch wire 19/25 in the upper with the activation in the area of 2.2 and 2.3. I add negative torque on 2.2 and I add positive torque on 2.3. Because the root of 2.2 is still located palatally, I make a bend for a negative torque in the area of 2.2. The elastics for crossbite allow me to keep the bite open in the posterior, and I add impala in triangle. It's a 5-ounce elastics in order to correct the open bite. In December 2021, we have stopped the expansion while keeping the triangular elastics in order to completely close the bite. I have put the upper arch wire 18/25 because I'm planning to rebond the bracket on 2.2. We have the comparison before and 1 year throughout the treatment. What we see in the upper jaw is a huge expansion. I would say even it's an exaggerated expansion. It has allowed to solve all the issues initially present, such as crossbite, which has been completely corrected. And in 24 months, we haven't used anything other than the Damon system. We have achieved this expansion thanks to the Damon system work only. This has not been completed yet, so I cannot show you the final photographs yet. Let's take a look at another patient with a difficult expansion, and I would like to demonstrate this case. This is class 3 surgical. It's an open bite. It should have been a surgical patient. You see that this is a patient. This bite pathology is due to the incorrect tongue position and swallowing issues. So we see class 3. On the right, we have the direct bite on 4.4. There is a canine contact. On the left, the canine is located between, the tongue is located between the premolars. So we can see that this is very severe class 3 with a complete rotation of the bite in the upper. The upper dental arch is triangular and narrow, and we see crossbite in 2.4, 2.5, 2.6. And we have a crossbite for the areas of 1.4 and 1.5. Here is our treatment plan with a torque calculation for every tooth and the elastic prescription. What we're going to use. Of course, I have explained it to the patient that because he's a surgical case, we would try to achieve the best possible improvement of the position of his teeth due to the oral device use. He needs to completely understand that we're only able to improve his situation, to compensate his skeletal anomaly or malformation, but we cannot solve it completely. Here we are several months into the treatment. You see stainless steel arch wires. The upper is 18/25. We have already gone through the expansion of the arch of the dental arches on copper night tie arch wires. I have used the tongue tamers in the upper in order to move the incisal group correctly. We have made the decision in order to close the gaps, which allows also to improve the vertical skeletal dimension. This is how we have decided to medialize everything to close the gaps. We use the arch wires, we use closed springs and elastics for transverse expansion and class 3 overbite in the frontal area. We have also added vertical elastics in order to obtain the desired contact occlusion. At this point, we have almost completely corrected class 3. The canines have a direct occlusal contact, canine on canine. We're still working on the canine position and the incisal group in the upper jaw, and we continue distally in the lower jaw to be closing the gaps. We are thoroughly controlling the whole process, because if the patient complies very well and wears the elastics very well, the results can come through very quickly. At this stage, I have made the decision to be closing the gaps in the upper right and lower left, and keep the gap on the lower right. Due to the time frame of the treatment, the patient and I decided to keep this left lower gap open. Here you see we have added light torque on the lower incisors in order to keep their roots in the bone and prevent their lingual inclination. On the upper jaw, we have used the TMA arch wire 17/25 in order to close the gaps and improve the bite with the elastics. Throughout our treatment, the expansion of the upper jaw remains sufficient, and we continue on improving the bite, detailing it, closing the gaps between the teeth. Here we have done the stripping of the lower teeth in order to close the black triangles. We have also shifted to a TMA arch wire 17/25 in the lower. We have added triangular elastics and trapezium elastics in order to close the bite in the front area. These are our post-treatment photographs. This treatment has been completed with a very acceptable overbite. But most importantly, please take a look at the expansion in the transversal plane that we have managed to achieve in the skeletal class 3. We compare what was prior to the beginning of the treatment and after the treatment. The expansion is quite significant, as you can see. We can assess the transformation with the improvement of the transverse volume of the upper jaw. This is our cephalometric scan and the panoramic X-ray, along with the facial photographs of the patient with a completely different profile. Everything has been achieved thanks to the huge potential of the Damon system, which, as you can see, has been used throughout the treatment with very light forces. Another patient with a similar situation, I would say, or probably a more difficult situation, in fact. This lady with skeletal class 3, a crossbite, virtually in all of the upper jaw, including the incisal group. Here we can, my colleague tried to move the centrals orthopedically into a direct bite, but actually all teeth have a reverse overbite, a negative overbite from 7 to 7. So we have a crossbite on the right and on the left, as well as the negative overbite or class 3 bite in the anterior. Mechanically, in our regular protocol, we follow all the techniques with various copper nitride arch wire, here upper and lower 18/25, as well as the palatal supports, palatal anchorage, where we give cross elastics throughout the whole treatment. Here you see the expansion after 6 months of the treatment. The upper jaw has expanded a lot. Of course, we have the compensations in the dentoalveolar level in patients who actually require surgery. This demands very high precision and very thorough approach from us. We should rely on the patient, on the compliance on the patient. I have used class 2 elastics on the left and class 3 elastics on the right, as well as central midline elastics, because we have almost 4 millimeters of malposition. Everything of these must be used. Here we have stainless steel arch wire, which are perfect in order to achieve the movement of the teeth, in order to achieve midline alignment. We continue with our correction, and you can already see the improvement of the midline. The patient continues to be complying with the elastics protocol. We have 5/16 elastics with 5 ounces of force. We see a perfect expansion and an almost perfect midline. We just need to close the gaps between the teeth and improve the bite and occlusion. As we go on with the elastics to move the teeth into the correct position, we see that the midline has been established correctly. Then we move to TMA arch wires, purple, that have a mobility which is characteristic to TMA, but which are gentler and more plastic than the classical TMA wire. This is why we can still continue the movement of the teeth as we desire. Also, we use the elastics to close the bite after I have removed the buildups. These trapezium elastics allow the improvement of the occlusal contacts, and this is the final outcome with a complete correction of the crossbite in the lateral areas and in the anterior area as well. We have corrected the posterior and anterior crossbite in class 3. At the end of the treatment, we have refabricated the crowns. So here you can appreciate once again the improvement of the volume of the upper jaw and the length of the jaw, as well as its width. It's quite significant. And coming back to the roots questions, in all of these cases, we have not a single problem of denuding or extract or a root going beyond the cortical bone, because we followed very strictly our treatment protocol. Another peculiar case. All of my patients are peculiar and special, but I have chosen the most special ones. This is a surgical case. All of these patients have refused to undergo surgery for what seems to me clear reasons. We have an open bite patient, a crossbite on the left and direct bite on the right. We see that the shape of the upper dental arch wire is a saddle shape, whereas in the premolar area there is no space for the tongue. This led to an incorrect tongue position, which led to an open bite. This is the cephalometric and panoramic studies of the patient. On the cephalometric, we see the increase of the height in the anterior, and we appreciate the open bite. It's important here that I wanted to improve the bite by expanding dental arches without extruding the anteriors, because they are already in a correct position for themselves. This is why I don't want to extrude the anteriors, because otherwise it will lead to a gummy smile. The first appointment, we have bonded the Damon Q system with copper 9 tie 0.14 in the upper and the lower. During the second appointment, we have added mini implants in order to support the anteriors in their initial position. Then I have added 2 metal ligatures in order to hold the incisors in a stable position, which means that our arch is going to be active in the posterior areas only. Over some time, I add elastics for crossbite correction, 5/16 inch, 4.5 ounces, and I add 14/25 copper night tie arch wire in the upper and the lower. During the second appointment, you see that after 10 months, the dental arches have already expanded on the 14 copper night tie arch wires. Now we use 14/25 copper night tie for 10 more weeks. And in December, we see that these arch wires, together with the elastics, have transformed the dental arches. Now we are ready to switch to copper night tie 18/25 with the elastics of 6 ounces of force, while the mini screws keep the position of the upper incisors. After the 18/25 copper night tie arch wires have done their jobs, I have used stainless steel 16/25 arch wires in February in the lower jaw, while keeping the previous 18/25 copper night tie wire in the upper. In May, we keep the elastic arch wire in the upper jaw with cross elastics. In June 2019, I add the reverse curve 19/25 in the upper in order to intrude the posterior teeth in the upper jaw because our anterior area has been fixed and their extrusion is prevented. This is why we will see only the intrusion of the posterior teeth. In July, I have started a more active intrusion of the posterior teeth. I have added mini screws labially and palatally. You still see the aftermath of the anesthesia in this patient. And I am still using soft, gentle copper night-eye arch wires. I have also added chain in the posterior area. I'm changing the chains in order to provide for a very gentle intrusion because the patient is very dolichocephalic, so I'm trying to correct the SPI curve as much as possible. Here, where the intrusion of the posteriors have improved and the SPI curve has been flattened a bit, we still see that the anterior teeth are still in the same initial position, which means that we have moved the upper arch a bit higher, and now I'm moving the lower arch in order to close the bite, so I'm achieving extrusion with triangular elastics. We can also use box elastics. We put the stainless steel arch wire in the upper to stabilize it, whereas on the lower we use copper night-eye 18/25 arch wire, so the work will be completed with the use of the force of the elastics. By July 2020, we already see good contact. Then we continue to improve the bite by using ram, crossbite in triangle and box. In November 2020, as we continue the use of the elastics, I have freed the upper anteriors in order to close the bite, because we're practically at the close bite right now. Now you see almost the conclusion of the treatment. I remove the palatal mini screws and the build-ups and continue to improve the closure of the bite. In April 2021, we see almost a completely closed bite. I just use TMA wires in order to detail the bite and occlusion. The patient continues to wear the elastics. And in June 2021, the treatment has been completed. We see class 1 on the left and on the right. We see the midline correctly positioned. The bite is closed without an extrusion of the upper anteriors. These are the follow-up cephalometric and X-ray and panoramic X-rays. You see the before and after panoramic X-rays. And these are the photographs after all the restorative work required has been completed in order to restore the anatomical shape of the incisors. We also take a look at the aesthetics. The patient is extremely satisfied. We have achieved the correction of all initial issues and problems. And in this case, in these photographs, we can also appreciate the expansion that we have managed to achieve in the transversal plane thanks to the Damon system. And let me remind you that we didn't have to use any additional or adjunctive devices. And there is no gummy smile provoked because we didn't extrude the anterior group. These are intraoral photographs which allow us to appreciate the dentoalveolar changes, the dentoalveolar transformation. These are the lateral views. And the occlusal views, where we see the changes that have been achieved simply thanks to supporting the dental and oral tissues without any recessions, because we simply followed the protocol, we followed the technical details and the elastic use protocol. Another clinical case, we have achieved significant expansion on the Damon system. It was initially quite complex because the patient has skeletal class 3 with mesial bite and reverse overbite in all areas with a jaw deviation, a complete reverse bite, and crossbite from 1.1 to 2.5. Naturally, we will be aligning and expanding the dental arches. We also see a malposition of a midline, almost to a lower incisor gap. We let the copper night-eye wires so that they work as usual. We achieve alignment simultaneously in the upper and the lower. We use TADs on the lower lingual part of the teeth, and we wear the crossbite correction elastics both in the posterior and in the anterior. Here we have copper night-eye 14/25 in the lower, and we give light force 3-ounce elastics. We go on through the treatment. We already see good expansion in the upper. Crossbite has been corrected, and our main tasks at the moment are the restoration or correction of the midline alignment and some bite improvements. I'm going to go back to the beginning first in order to show you how were the premolar 4.4 and canine 1.3 contacting. You see the very serious, very severe malposition. And this is what we have achieved in the contact of 1.3 to it's already an ideal class 1 bite, which we stabilize with the help of the elastic. Simultaneously, we continue using elastics to correct crossbite and diagonal elastics to normalize the midline and the centrals. We already see class 1 on the right and on the left. Sometimes I go back to class 3 elastics in order to achieve hyper correction. We close the diastema and interdental gaps. I rebond some elements in order to improve their position, and this is the completion of the treatment in June 2017, where we have corrected class 3 on the right, crossbite on the right and on the left. We have realigned the midline, and we see class 1 on the right as well. These are the before and after photographs. As you can see, we have all the roots covered with bone. We can also see there is no issues with the joint or the articulation. There are no pathology. There is a slight recession of the gingiva. We cannot but notice the significant expansion, while the recession, though a lesser one, was present prior to the treatment as well. We see that the jaw has come back to the center because the misalignment was due to the wrong position of the lower jaw, and the patient is very happy with the non-surgical outcome. We have already spoken about crossbite being able unilateral or bilateral. So when we see a mixed dentition, we can still use the Damon system in order to correct the crossbite. So we have a mixed dentition patient, and we can use a partial system, degainer, which is used on incisors and molars in order to create posterior spaces. It is used in the cases where early deciduous teeth were removed and the gap for the natural eruption of the permanent dentition was lost. Initially, we bond the brackets on the incisors only, and after aligning them, we add tubes on the molars and we add open springs. The protocol is as follows. First, we apply low torque brackets on the incisors, upper and lower. Then we use snap-link molar tubes on the first molars, preferably snap-link, because they have enough negative torque. We use sectioned copper nitai 14 arch wires only for the incisors at the beginning. Then we switch to copper nitai 14/25 arch wire up to the first molars with open springs in order to solve sagittal issues of the dental arches. In such cases, as this one, we need to not section the arch wire beyond the first beyond the first molar, so that the open spring can continue its work efficiently. So we simply bend the wire beyond the first molar, and then we switch to TMA 17/25 arch with the open coils, open springs. And after the springs have worked and created enough space, we switch to the closed coil to preserve the spaces achieved so that the permanent dentition can erupt freely. At the beginning, when we use the 0.14 arch wire, we need to have mesial and distal stops in the center, and we leave about 3 millimeters of arch wire behind the bracket of the lateral incisors with a distal fold so that the springs can work its full potential. The open coil springs on the 14/25 copper nitai arch wire should be activated on one bracket and a half. This activation creates enough space for the eruption of the permanent teeth, and it's not overpowering the teeth. In order to reactivate, we don't have to replace the coils and springs. We just can use the stops and reposition them. Or we can use the flow. It may be necessary to apply a root mesial tip on the lateral incisors in order to prevent a mesial inclination due to the backfiring of the spring. So we can have this hypercorrection tip on the lateral incisors in order to counteract this backlash of the spring. Here is the example. We see the activated springs. We already see the first premolars erupting. We continue creating the space, and the more we look into the case, the more space is being open for a full eruption of permanent dentition. We have covered the crossbite problems. Now we will talk about deep bite. We have mentioned that the second goal that we work on after solving the crossbite is the correction of the vertical problems. Such as deep bite. It may be skeletal or dental. Deep bite, skeletal deep bite presents almost always with the strong muscles in the interior, predominant horizontal growth, lower facial height decreased of the lower facial third, a longer posterior skull base, and the so-called brachycephalic mandible. What is overbite? As we know, it is the vertical distance between the upper and lower incisor ridges perpendicular to the occlusal plane. This distance is called the overbite. It is important to assess why deep bite has been formed. Was it due to the extrusion of the lower or upper incisors, or both? In order to assess the reason, we look at the ideal position of the lower incisor. It's always our starting point from where we check our arch wire and dental wire. The margin of the lower incisor must be 1.5 plus minus 2 millimeters on the occlusal plane. So the distance, so this should be 1.25 plus or minus 2 more millimeters, whereas the distance from the upper incisor should be 2.5 millimeters plus minus 2. In this picture, we see a deep bite due to excessive extrusion of the upper incisor, whereas the lower incisor is in the correct position relative to the occlusal plane. So the reason of the deep bite is exclusively the extrusion of the upper incisor. Whereas here, we see the opposite. We see that the lower incisor is way higher than the occlusal plane, way higher than 1.5 millimeters above the occlusal plane. So the deep bite here is due to excessive extrusion of the lower incisor. There is something important that we always need to consider, because today we cannot plan a treatment without considering the facial or smile aesthetics of our patients. We use biomechanics, but we should look beyond the cephalometric study. We should look at the aesthetic aspects. That is why we see the degree of the exposure of the upper incisors and the smile, which is the definitive factor in the smile aesthetics. We also look at the length of the upper lip and the gingival exposure. If a deep bite was caused by the extrusion of the lower incisors, and we also see a gummy smile in the same patient, we should prioritize the correction of the upper incisors, because we also need to correct the gummy smile. If we put the lower incisors in the correct position relative to the occlusal plane, we will never be able to correct the gummy smile, or, which is even worse, we may stimulate bite opening. If, on the other hand, the deep bite is formed due to the upper incisors, but we have a correct exposure of the teeth in the smile and there is no gummy smile, then we would have to intrude the lower incisors. Aesthetic parameters should be prioritized before the skeletal parameters, and aesthetic planning is extremely important today because the motivation of our patients is aesthetic improvement. Let's take a look at the biomechanical sequence to correct deep bite. It's almost classical, as in most Damon system treatment protocols, with just some special arch wires added. So we start with the round 14 copper night tie wires, switching then to 14/25 copper night tie wires. Sometimes we can even use 18/25 or 0.18. After the copper night tie 18/25 has achieved the expansion, then we can use nickel titanium arch wire 17/25 in the lower, or 19/25 in the upper with a reverse curve. Reverse curve arch wires can be very useful to open the bite or to correct the part of the dental arch that is necessary. After that, we almost always go back for a few weeks to copper night tie 18/25 arch wire. Later we will see why it is necessary. Then we follow to stainless steel arch wire in order to correct the class, and then the TMA finishing arch wires. When we use arches with curves, we must always consider the fundamental rules. We mount second molar tubes. The second molar should always be bonded, and in any class, in any case, but in most cases when we use arches with curves, it is absolutely obligatory, because otherwise we may lose control of the arch wire. We must apply either chain or metal binding, metal ligature from 3 to 3, and we should avoid proclination of lower incisors. In order to avoid lower incisor proclination, we may use various tools. This is stripping, if the anatomy allows that. The stripping gives us the opportunity to keep the position of the anteriors in an absolutely upright position. We can use low torque bracket. We can use a chain from 3 to 3, overlapping the brackets. All of this will allow us to keep the axis of the teeth and prevent the proclination of the lower incisors. Reverse arch wires in the lower jaw are only used if the SPE curve is too accentuated. And we never put reverse arch wires with additional torque on the lower jaw of 20 degrees, for example, 20-degree torque. Of course, we can be sold them and we can easily buy them, but we should never use them. Another important area in the deep bite correction is when we ensure that we have buildups in order to open the bite. It allows us not only to open the occlusion, but we can also use various force and achieve different result in the area of application of that force. For example, we use anterior buildups when the incisors and the upper gum have correct exposure in the smile. So we only want to achieve posterior extrusion, whereas we use posterior buildups when we need to correct a gummy smile. That is, when we want this effect of the opening the bite happened and occurred in the posteriors. This system, this scheme shows us that the anterior buildups with posterior short elastics allow for a vertical effect, that is a posterior extrusion with the increase of the lower facial height, as well as the correction of the deep bite thanks to those changes in the posterior areas. And on the contrary, posterior buildups with reverse curve arch wires with posterior elastics in a box, they keep posterior areas stabilized with a total intrusion in the anterior. Like this, we do not only correct the deep bite, but we also correct the gummy smile. Let's take a look at a few clinical cases. We see a patient with an overbite or with a deep overbite with a various degree of crowding with some teeth missing. We analyze the cephalometric X-ray where we see that the Spies curve is more pronounced in the lower jaw, but the reason of the deep bite is mainly coming from the upper. We select the torque for the teeth of the patient because we can select torque for each tooth individually. This is why 1, 1, 1, 3, 2, 1, 2, 3 will receive brackets with super torque. This is the bonding appointment. We bond standard torque and super torque on 1323, 1121. These are round arch wires, upper and lower, copper night tie. We let them work for about 10 weeks. Then in June, we have mounted molar tubes with a round copper night tie 18 arch wire because the crowding doesn't yet allow us to switch to the rectangular wire, whereas in the upper I can already use the copper night tie 14/25 arch wire. Here I have also added an open coil spring on 1/6, class 1 elastics. Upper arch wire is now copper night tie 18/25, whereas in the lower it's copper night tie 14/25. We have almost a complete alignment of the both arches. We have zebra elastics on both sides because the system is aligning everything nicely, correcting the bite. I am correcting the class. After some time, I have added a chain on the left in order to close the gap. Also, I'm mesializing the molars, whereas on the right, I'm creating and supporting space for implantation. In September 2019, I continued the treatment. I have performed stripping in the lower. In the lower, I have put copper night tie 18/25 wire with a chain in order to avoid proclination of the lower incisors. This is why I've stabilized them. On the upper jaw, I put a reverse 19/25 arch wire. With the use of this arch wire, I'm going to intrude the anterior, extrude the posterior, and increase the torque. Actually, I see a lack of overbite, and without enough torque and without enough contact, I will not be able to achieve a correct bite. In October, I have mounted stainless steel arch wire 19/25 in the lower jaw. It has been finished and it's now the stabilization stage. I continue working with the maxillar. It's a reverse arch wire with the class elastics. We see a better torque in the incisor group, which means that the elastics have provided for a very good result. In November, I still use the reverse curve arch wire and elastics in the upper. In January, I add curves for the anterior group in the TMA arch wire in order to improve the torque, so that I can make it even more perfect, and I continue to improve the class of the bite. The patient continues to wear the elastics. Here we have TMA arch wires and extrusion folds in order to improve overbite. I also have elastics to improve the canine torque, and I continue to close the bite. This is the final outcome. We will continue in order to close black triangles. We have also improved the shape of the teeth. So this is our aesthetic result, the before and after photographs, the final cephalometric and panoramic x-rays. We can appreciate the good expansion of the arches, which has been achieved thanks to the correction of the deep bite. The deep bite has been completely corrected. And here we see another case. It's very serious deep bite with a complete class 2. On the cephalometric x-ray, we see the occlusal plane and the lower incisors are a bit extruded, but the main reason of the deep bite is the upper incisors. The intraoral photographs, a complete class 2. There is a very big discrepancy in the dimensions of the maxilla and the mandible. We have chosen the torque, super torque on 1311 to 321. This is the bonding of the bracket system around copper nitai 14 wire in the upper and the lower. We see now copper nitai 14/25 arch wire in the lower, zebra class 2 elastics. We have also rebonded 4-1 bracket. We have added build-ups for disocclusion. We continue using the elastics. We already have stainless steel arch wires and 6-ounce elastics. And in July 2019, we put TMA arch wires, 19/25 in the lower, 18/25 in the upper. In the upper, it's a copper nitai arch wire. We have rebonded 1-2 and 2-2 in order to improve the rotation. In July 2019, we have a correct intermaxillary position. We only need to improve the midline and contacts. We use class 2 elastics. In this case, I give them in a triangle shape in order to keep the bite in the canine stable, but I leave a small horizontal component that will continue to correct the bite class. In October 2019, we already see the final result with an ideal bite on the right and on the left with the aligned dental arches of the upper and lower jaw with a complete correction of the deep bite. This was the initial situation, and you see the final outcome. We can appreciate the changes that have occurred in the upper jaw, about how it went higher of the occlusal plane, and the position of the incisors relative to the occlusal plane is now correct. Before and after. And the final follow-up X-rays comparing the cephalometric X-rays before and after the treatment. And we can appreciate the smile aesthetics after the treatment has been completed. Before and after. Then we had small aesthetic detailing of the smile. Whitening was performed. Another case of a skeletal deep bite. This lady has a decrease of the size of the lower facial third. This would also be a surgical case, and we have suggested a surgery for her, but she refused. And we need to achieve everything possible to compensate her case in order to improve her smile and her profile to the best possible outcome, but without surgery because the patient has refused to undergo surgery. We can appreciate the occlusal plane on the cephalometric X-ray. We see that the lower incisors are a bit extruded relative to the occlusal plane, whereas the upper incisors are completely extruded, which means that the reason for the deep bite comes from the maxillary incisors. These are intraoral photographs of the malocclusions, class 2 on the right and the left, deep bite. It's an adult patient. This is September. We have selected torque. We have decided to use super torque on the same teeth, 1323 to 111. Copper night tie round arch wires, 14, size 14. And I have immediately added class 2 elastics. I have wanted to achieve disocclusion in the anterior, but the patient was very uncomfortable due to the strong disocclusion. This is why I have added posterior buildups instead of the anterior buildups. In every case, in this case, I use short elastics because I want to achieve posterior extrusion in the first arch wires. Then we saw her in February 2018. We have completed the alignment and expansion on copper night tie arch wires. Now we use 17/25 reverse arch wire in the upper and the lower. They are used to open both dental arches, to align the SPE curves, to improve the torque in the upper and improve the overbite in the upper. In April, we have rebonded 3.5. which had separated. 16/25 stainless steel arch wire in the lower and reverse curve arch wire 19/25 in the upper. I give mousse elastics to correct class 2. In the maxilla, I add positive torque on the canines because the axis of the canines, of the roots of the canines, makes occlusal contacts almost impossible. And this is the photograph. These are the photographs throughout the treatment so that we can see the exposure of the incisors in the smile as well as the exposure of the gingiva and to appreciate the profile of the patient. In July, we have rebonded 1.2 through 2.2 in order to improve their position. In the upper, we use 19/25 arch again with a 20-degree positive torque. Take a look at how well the canines have uprighted so far. I need the positive torque in order to improve the bite class. I haven't connected the lower second molars because in such situations I try to do it as late as possible because I want to create the best conditions for the lower arch to move forward. This is why I leave the second molars unbonded at this time. September 2018. We have mounted stainless steel 19/25 arch wire in the maxilla. Now we work on the bite because the vertical problems have been almost completely solved. Our dental arches are well aligned and uprighted. I use class 2 mousse elastics during the day, and we add a second elastic on each of the mousse during the night. So during the nights it's the double mousse class 2 elastics. A follow-up throughout the treatment. After we have been assured that double elastics do not create discomfort for the patient, we decided to add the daytime double elastics wearing in order to improve the intermaxillary dimension. In June 2019, on the right, we see class 1. On the left, we have almost achieved class 1. So elastics and stainless steel arch wire allowed us to have achieved class 1 occlusion. Here I have bonded brackets to the lower second molars and switched to copper night tie 18/25 in the lower jaw in order to include the second molars in the system. We have added mousse elastics in triangle. We hold the canines in the stable position and we add the horizontal force to improve the class of the bite correction. In October, we have rebonded certain brackets. This is why we switched back to copper night 18/25 arch wire in the upper, whereas in the lower we have switched to stainless steel 19/25, and we have done stripping of the lower incisors. And we have added a chain in order to stabilize the lower incisors. Then we continue with copper night tie 18/25 in the upper. We improve the dental aesthetics. The class 2 elastics continue to work in the triangular shape. I have also added class 2 elastics additionally because there is always a tendency that we might be missing something, so I have decided to keep them on. In January 2021, we have debonded the system. We see class 1 on the right and on the left. The teeth are perfectly aligned. The midline is at the center. The aesthetic result, as you can see, is very beautiful. The smile, the profile. I think I have done everything possible to compensate for the skeletal problem, to correct the deep bite. Prior to the treatment, we couldn't even see the lower incisors. Here we can compare the x-rays before and after the treatment. We see the inclination of the lower incisors, and we see that we have achieved everything thanks to the dentoalveolar movement, even though it was a surgical case to begin with. But we couldn't have achieved more than what we have done. Aesthetics and functions are both considered well. We can see how much the bite has been expanded thanks to the Damon system. These are the occlusal views. And now we switch on to the next clinical case. This young lady with a deep bite. A very pronounced occlusal anomaly. These are the intraoral views, the x-rays. We check the occlusal plane, and we see again that the deep bite is mainly due to the extrusion of the upper incisors. We see a very deep bite, and we don't have occlusal contacts in the anterior. We have selected SuperTalk on canines. In November, we have bonded the Damon Q system on the upper and lower jaw with SuperTalk on the upper canines. We have round Copernicti 0.14 arch wires. These are super elastic, light force arch wires, which will help us achieve intrusion during the first weeks. It will happen very quickly. The patient will see improvement very fast. This is February 2019, 3 months later. We have put the Copernicti 0.18 wire in the lower and 14/25 Copernicti wire in the upper. In April, Copernicti 18/25 in the upper and Copernicti 14/25 in the lower. We see already the alignment of the two arches relative to the occlusal plane, and virtually simply Copernicti wires allowed to correct the deep bite. We have added class 2 elastics as well. These are zebra elastics. At this phase in the upper jaw, where we have seen a very pronounced speak-through, we have switched to stainless steel arch wire 19/25, and we work with the copper night-tie arch wire 18/25 in the lower, and of course the patient is wearing class 2 elastics. In August, we have used a reverse curve wire 19/25 in the lower in order to flatten the Spies curve, which is still quite pronounced, but the patient has been warned that she must follow her appointment protocol because I need to thoroughly control everything that happens. I need to see her every month and a half in order to see how this wire works. We keep class 2 elastics on the left, whereas on the right we have a triangle elastics in order to close the bite and improve occlusal contacts, as well as to stabilize this position. In November, I switched back to 18/25 copper night-tie wire in the lower jaw because the previous reverse curve wire has worked very well. In the upper, I switched to TMA 19/25 arch wire for detailing the alignment before removing the system. I used class 2 triangle elastics, mousse. Also, I tried to keep a very good canine guidance. January, finalizing the treatment, closing the gaps on TMA wires. I add a small curve in order to improve the position of the incisors. 19/25 TMA wire in the lower jaw, and this is already the outcome with the correction of the deep bite with the perfectly aligned and upright dental arches with class 1 on the right and on the left. Follow up cephalometric and panoramic X-rays. The aesthetics and the before and after X-rays. This is the final outcome. The central position of the midline has been restored, the before and after pictures, intraorally and facially. Laterally, we can see how the dental arches have achieved good position relative to the occlusal plane. And how well we have managed to improve the Spies curve in the upper jaw. The occlusal views before and after, and the face and smile aesthetics. And her profile. We have also decided to conduct teeth whitening in this case. And here is another clinical case. This is an adult patient with a deep bite, which in this case is mostly due to the position of the lower incisors, not the upper incisors. We also see an orthopedic construction, the restorations in the mouth. There is the retroclination of the incisors, so the torque is highly negative. So the real reason of why the patient came to me was the complaint on the rest of the restoration. He didn't like that one canine was twice as large as its contralateral counterpart. In both arches, we see a reverse Spies curve, and we have severe crowding in the lower with a rotation of almost 45 degrees in most of the teeth. Selecting torque, we use low torque in the lower incisors and super torque brackets in 1.3, 1.1, and 2.1. In May, we have mounted the Damon Q system with 0.14 Copenhagen wires and anterior buildups. In this case, I have bonded the bracket on 1.3 extremely high, almost at the gingiva, in order to extrude it. We have a very natural amount of force, very light force, so the whole tooth will be moved with the periodontal ligament, with the bone and the gingiva, which will hopefully help us correct the free gingival margin. I have also stripped the occlusal position of 1.3 and 1.2 in order to allow space for the extrusion. I have also separated 1.4 in order to provide more space for the canine movement. The wire is copper nitai 0.14. Of course, due to the crowding, some brackets were not bonded immediately, so I used ligatures in order to slowly move the teeth towards the wire before I could put the wire through the bracket. 5 months later, after we're still wearing the round copper nitai wires, I'm going to keep them for a long time because I needed them to align the maxillary dental arch. As you can see, the canine has moved down quite significantly simply on the 0.14 copper nitai wire. Now we use a chain in order to close the gaps because all teeth have been uprighted. Now we switch to copper nitai 14/25 upper and lower. The tooth continues to come down. We have almost reached the level of the canine on the contralateral position. I have added the metal ligature in order to prevent any gaps. I give elastics, kangaroo for class 2 correction, 4.5 ounces, 3/16 of an ounce. And we just let the wires do their job, expanding dental arches. There is also a small misalignment that needs to be corrected. In November, we go to January. I keep 16/25 copper nitai in the lower because I haven't achieved the desired expansion and alignment in the lower jaw as yet, whereas in the maxilla we have switched to copper nitai 18/25. It's almost perfect right now. We are practically ready to finish our work in the upper jaw with just finalizing some transversal issues. We see bite correction going very well. I'm moving forward quite easily. This is April 2013. We see stainless steel arch wires 19/25 because we just do some minor bite and occlusal contact correction with everything else being uprighted and aligned. We have class 2 elastics Impala with a diagonal elastic for the night in order to correct the midline. I've also did a small stripping in the lower jaw. In June 2013, we switched to TMA 19/25 purple wire in order to finalize the bite correction. We have rebonded the tooth bracket in order to improve the position of this canine. In October that year, we have rebonded the bracket on the canine tooth because I wasn't happy with its position. I have switched to stainless steel wire in the upper jaw, and I continue with the elastics as well as creating space for lateral incisors. One of the laterals is going to be restored with composite, and the other one will be restored anew. This is the final outcome. We have debonded the system. We have restored the mesiodistal size and dimension of both upper and lower dental arches. We have conducted implantation in the area of 1-2, which was later restored. We have changed the restorations on 1-3 and 1-4. We see class 1 on the right, and on the left we see the perfect midline restored. And I love this clinical case because we were solving restorative issues, we were solving dimensional issues thanks to the Damon system, of course. Please remember as well that this is an adult patient which has its limitations, but thanks to our system, we have made huge progress compared to what was 30 years ago. Take a look at his profile, at his face, before and after. I like the changes a lot. You see that his soft tissues, the soft tissues of the face, look more relaxed. And we see that other than restoring and improving his dental arches, compensating skeletal changes, we also see an improvement in the muscle tone. Now his muscles and soft tissues are more relaxed and balanced compared to his situation with malocclusion before. Another patient with a gummy smile in this case, together with a deep bite. The lower jaw is thus retropositioned. In these photographs, we see that the chin is in a posterior position. It's very distal compared to the upper lip. The difference is almost 1 centimeter. In the cephalometric X-ray, we see that the incisors in the lower jaw are positioned correctly, so the deep bite is mainly provoked by the upper incisors. We see that the incisors are all blocked and are positioned, are in a retro position because of this blockage. So our correction will come from the upper jaw, especially because we have a gummy smile. We have selected Super Talk for all anterior upper area from canine to canine, and we have also can appreciate how much the gingiva has suffered due to this malocclusion. In November 2011, we have started the treatment. We can see the retro inclination of these incisors. We have bonded the bracket system with the previous reconstruction of the incisors, which I always conduct prior to bonding the braces, so that I can position the buildups in the most accurate fashion. In this case, the buildups were provided for a smaller height in order to intrude the anterior segment quite actively. We start as usual with around 14 copper night tie wires in the upper and the lower. The anterior buildups. Then we switched to April 2012 with a quite well-aligned lower dental arch. And the upper jaw, we see the teeth quite well aligned and uprighted, but there are some issues with the Spies curve. We use 18/25 copper night tie wire in the upper and the lower, alongside with the class 2 elastics. They correct the class, but they also provide the extrusion in the posterior. At this stage, we have rebonded bracket on 1, 3, and 4, 4. We have used a reverse curve wire 19/25, pre-torque to 20 degrees in the upper jaw, with 18/25 copper night tie wire in the lower. Like this, we want to improve the Spies curves and get a better canine guidance with better torque on the incisors. That's why we use the reverse curve pre-torque to 20 degrees. At this point, we have stopped wearing the elastics. I can't tell you exactly why, but most probably it was because I was changing to 20/25 copper night tie wire. Now in September 2012, we have switched to a stainless steel wire in the lower jaw, and we maximize the bite corrections. We correct the class of the bite. Our reverse curve bite improves the axes of the canines, improves the Spies curve and the canine guidance. We keep the chain in the lower. We continue the elastics through the next stage. Now we see December 2012. It is still the reverse curve wire, which has been working for many months. In such cases, it is very important to control your patient and follow up on their changes quite regularly. Despite everything, the reverse curve wires should have worked a long time. We have added class 2 elastics as well as the midline elastics for the night time. On the left, it's a double elastic because on the left, the bite class correction goes worse than on the right. And here is the outcome of our treatment. It's not ideal if you look at the midline. I would have probably tried to improve it by 1.5 millimeters, but the patient was really eager to quit and to stop the treatment. This is the before and after comparison. It is most important to take a look at the length of the dental arch, the degree of the improvement. We have restored the position of the upper incisors and we have restored them as well. You see the lower incisors which were not showing in the deep bite prior to the treatment. The contact was directly on the gum, and now the most interesting part, incredible changes in the profile of the patient, in her face. You see the jaw has expanded and opened up vertically and sagittally. It could move forward and position itself perfectly well relative to the upper jaw, and naturally the face looks younger because the nasolabial fold was caused due to the retroposition of the lower jaw. Take a look at the soft tissues, the tissues of the face. They look relaxed and balanced. The profile has transformed. In the frontal pictures of the patient, we see that the gummy smile has been completely resolved. After the treatment, we see a perfect smile arc, a perfect smile with a very good upper incisor exposure. The smile arc completely follows the line of the lower lip, as it should. All aesthetic parameters have been achieved. Take a look at her cheeks, at her eyes, at the zygomatic area. Her eyes became brighter. At this, I would like to complete my lecture. I hope I spoke in enough details, quite precisely and clearly. Thank you very much for your attention. It was a great pleasure to speak to you. Thank you and bye-bye.